you, Robin. Thank you, Robin. Welcome, everyone. Thank you for inviting me and having me. Just a disclaimer is that I am only seeing my slides. I don't see anything else. So if there is any questions or any comments, please feel free to interrupt me. I will be talking to you about the focal cortical dysplasias, integrating neuroimaging and genetic insights. So I do not have any disclosures that are pertinent to this talk. The objectives are to review the updated classification of the focal cortical dysplasia that was put out by ILA in 2022, discuss how genetic testing can influence MRI lesion detection, and really then bring it together with role of brain mosaicism, the role it plays in epilepsy surgery decision-making. So first, I want to start off by the first to set out the stage is to really understand that we all know there is the typical path to epilepsy surgery usually takes about 2 to 8 years, depending on and there are many different factors that can delay epilepsy surgery. At times, it's actually making the accurate diagnosis. At times, is and many other factors like even detecting a lesion, really understanding the epilepsy, getting the patients to epilepsy surgery sites. And what I like to plead is that in this pathway, now there is a very significant and important role for integrating genomics into this long pathway that could potentially make patients bring more precision therapy to the way we approach pediatric epilepsy surgery and for adults alike. Now, I want to start by a case to set the stage. This is a 10-year-old boy who started having seizures at 2 years of age. However, he was not diagnosed until he presented with a bilateral tonic-clonic seizure at 7 years of age. This patient always continued to have a non-focal exam. I met the patient when the patient presented to the emergency department with bilateral tonic-clonic seizure at 7, and this was on background of having had a diagnosis of GERD episodes, persistent episodes that were being treated as GERD and reflux since 2 years of age. Patient also was diagnosed with alpha thalassemia trait, had joint hypermobility and hypopigmented macules and multiple allergies. The patient didn't have any other risk factors, no prenatal complication, no febrile seizures. There was an interesting family history, no family history of epilepsy, but there were other family members with alpha thalassemia trait. And as you can see, it was only our index patient that had a diagnosis of epilepsy. And otherwise, it was just a maternal cousin, distant cousin that also had epilepsy. However, a majority of the family members were diagnosed with alpha thalassemia trait. So this is the journey, this patient's journey. It started in 2016 with these episodes that were really very brief, and I'll go into the semiology in a little bit, but they were very brief. He always had a bad taste in his mouth. They were very stereotyped, but but only occurred at night, rarely during the day. And given the diurnal fluctuation and variation, the patient was diagnosed with GERD. So the diagnosis of epilepsy was only made in 2021. The subsequent MRI was negative, and then we proceeded to complete a genetic testing in 2023. Already you can see 7 years into the onset of epilepsy. Already we're on that typical path of getting patients to the correct diagnosis. So the epilepsy panel reviewed a full gene deletion in the NPRL3 gene. This was inherited from mom. This gene has a very varied and decreased penetrance, variable penetrance. So it is not uncommon that only our patient had a diagnosis, had a manifestation or presentation with epilepsy. We know this gene is associated in ILA database with focal cortical dysplasias, and also has been associated with autosomal dominant familial focal epilepsy. Now, of interest, and interestingly enough, there was also a copy number variant loss in the region of the chromosome 16p13.3, and this resulted in a whole gene loss that included both the NPRL3 and another gene, but this genomic location was very close to the alpha globulin gene cluster on chromosome 6p13.3, which explained why there was this family history of thalassemia, and this would have explained both the patient's genetic diagnosis and thalassemia. Now, this is now a patient that we know that based on the genetic diagnosis could have a possible, a majority of patients with this, with NPLR3 have a positive MRI. So we went back to the semiology, and the semiology was in events that, like I mentioned previously, there were brief episodes of feeling this sweet taste in his throat, following feeling very scared, and choking episode that then was generally followed by walking randomly in and around his room. These lasted less than 1 minute, and after the episode, he would return to baseline. These were mostly nocturnal, rarely occurred during the day. So we do what we do in our epilepsy surgery, which we try to really localize and understand where the seizures are coming from. So now we can, based on this diagnosis, which now puts, makes a likely diagnosis of focal cortical dysplasia more likely, to go back to the MRI and see if we can find a lesion. So as we went through the different kind of practice of semiology, MRI, fMRI, and PET, we were really now being focused into the insular opercular region, and the ictal EEG had shown some left temporal discharges. The MRI was normal. fMRI was left language dominant, left dominant for language. PET was inconclusive, and neuropsych had showed some lateralizing value, but for the most part, it was intact. So not really. Not giving us a lot of indication for temporal lobe involvement, given that this patient had been seizing for a very long time. So I'll leave you with this case, and we'll go on the journey of this talk, and then we'll go back to bringing it all together with better MRI visualization as well as the findings of the genetic results. So when we try to discuss patients in our epilepsy surgery rounds, like is a common practice, it incorporates many data of high field MRI, video EEG, neuropsych, PET, SPECT. And now what we're seeing more and more is constant and involvement and engagement of the genetics now in the main pipeline. We of course review the data. If there are clear surgical candidates, they go to surgical resection. If they're not surgical candidates, they go to palliative procedures. Now we know that we are including genetic testing, especially in those with intellectual disability. Now more and more in patients who have focal lesional epilepsy due to FCD, hemimegalencephaly, and TSC, and also patients with focal non-lesional epilepsy are patients that are a good candidate for epilepsy surgery. And what's now been also introduced is the deep sequencing of the resected brain tissue that may provide information regarding the long-term post-surgical prognosis. So the whole goal is that by doing the genetic testing, could it inform what our pathway, how this journey and this path will be for patients? Is just offering the genetic testing before the patient starts, before the patient undergoes surgery enough to know exactly what the genetic underpinning of patients are? These are the questions that we'll try to go through and answer during the talk. And also there's some evidence that some CSF liquid biopsy may play a role to detect some somatic mutations without really examining the brain tissue. So really for all of us as epileptologists, it all starts with finding a lesion. So our quest to find a lesion, and really it is a mission critical. It starts with semiology as we kind of were practicing with our patient. We then follow the semiology takes us to the MRI. Of course, the EEG plays an important role, and we incorporate the PET, and now there is the very strong presence of the genetic investigation and how that could zone in on where the lesion could be and what the expectations of how we can set up our expectations. So malformations of cortical development account for for most of the common surgical pathologies in children, with focal cortical dysplasia representing about 75% of most malformations of cortical development. The focal cortical dysplasia as an entity was introduced in 1971. It really included only what we know now as FCD type 2A and type 2B, with cytoarchitectural dysplasias. This was then in 2004 expanded expanded with Palmini classification to introduce the focal cortical dysplasia type 1. And in 2011, ILAE put out their first consensus statement. It revised the FCD type 1 and introduced the focal cortical dysplasia type 3. And we know the type 3 is really and it has three subtypes that includes the hippocampal sclerosis, low-grade tumors, and association with vascular malformation and early acquired lesions. And of course, these all have significant clinical implications and also can pose challenges. And as I said, the 2011 was the first time the ILA put out the statement. However, at that point, the genetic etiology had not really been well incorporated into the classification scheme. Now that moves us to 2022, where the ILA consensus really tried to redefine the classification, mostly really to introduce the mild malformations of cortical development, as well as the the new entity called MOGE, which is the oligodendroglial hyperplasia, and an entity of no definite FCD on histopathology as new categories. Their main quest was really to confirm now at this stage to confirm the importance of immunohistochemical staining and phenotype-genotype integration, and also involvement and bringing in the genetic arm. So with FCD type 1, we know that it's really characterized by abnormal cortical layering without any abnormal cells. So we do have three subtypes: type A, which is just abnormal radial cortical lamination. Type 1b is abnormal tangential cortical lamination, and 1c is combination of both radial and tangential cortical lamination. The MRI findings are difficult. It is very difficult to identify FCD type 1 at times on MRI. It does cause segmental and lobar hypoplasia or atrophy. There is abnormal sulsation and gyration, which is what you are seeing here. And comparing the two temporal lobes, it's now in this particular case is not hard to identify. And the type 1b is generally extratemporal. And type 2, which is what we are probably the most familiar with in terms of identifying on MRI. It's usually very gratifying to kind of see the typical appearance of FCD type 2 on MRIs. It is the one type that not only is characterized by abnormal layering, but also cytomegalic dysmorphic neurons and balloon cells. So type 2A is with dysmorphic neurons, and type 2B is with dysmorphic neurons and balloon cells. And this is now for FCD type 2A. We often identify see a blurring of a great white matter. It's not always visible on MRI, and it's harder to identify than type 2B. This is using some of the texture pipeline analysis that we applied on one of our patients. And admittedly, this focal cortical dysplasia was missed initially, and it wasn't until we ran the pipeline that we were able to identify the lesion in the patient, and the pathology confirmed that it was a focal cortical dysplasia type 2A. And this is, of course, the one that probably the lowest hanging fruit, the easiest, or the most distinguished and well described MRI feature of what you see what you see is the transmental dysplasia, or is the white matter signal that tapers from the crown of the gyrus or bottom of a sulcus towards the ventricle. Usually, you see it in the frontal lobe, as demonstrated here. Additionally, you can see blurring of the gray white matter junction, which is again not very specific to type 2B. You see it again with type 2A and also in type 1. An increased subcortical white matter signal on T2 weighted images is also reported. So now what the ILA recommends is that we all try to use this integrated multi-layered FCD classification, that it starts with the histopathology diagnosis. Of course, you do a description. This is done by the pathologist of the architectural and cytoarchitectural histopathology findings using H&E and appropriate immunostaining, and this is then classified accordingly based on the ILAE classification update. right? And then you would zone in the genetic findings, which is of course not standard of care in all centers, but you would then identify what tissue you're used to identify for genetic testing, whether it's fresh frozen or it's paraffin embedded tissue. And if genetic testing is not available, you explicitly indicate that. And then details of the MRI, whether the MRI was normal or abnormal. And also importantly, they like the description to also include whether it was just done by visual analysis or some post-processing to describe the anatomical location as well as the characteristics. And of course, you integrate it all together into a final diagnosis that would really integrate the histopathological finding, genetics, and neuroimaging. And this really encapsulates where the field is moving. And so before the ILA classification came out, a big effort led by Dr. Blumke and Dr. Najam was to look at, to gather 20 neuropathologists from 15 countries to complete 4 digital pathology trials of about 200 patient blocks obtained from 22 epilepsy patients. The patients were identified from Cleveland Clinic, but of course the pathologies were across the globe. They also separately sent genetic testing to 5 independent laboratories to sequence the FCD relevant genes, and they were looking at the interobserver agreement. And so what you see here is the results of what they identified is that they did the inter-observer agreement was done over 4 rounds. And to draw your attention, the round 1, anything that's in plain color is confirmed diagnosis, and anything that's not is sort of unconfirmed diagnosis, or they were not great inter-rater agreeability. So here you can see in round 1, as the FCD, green is an FCD type 2 and brown is undetermined. So as you move from round 1 to round 4, you see the cases, the undetermined cases shrink in size, and the confirmation and inter-rater agreeability was increased in for FCDs type 2. So what they did is when round 1, they were patients, the pathologists were only given H&E, and round 2 and to 4, additionally, immunohistochemistry was available. And also in round 3, Delphi consensus was introduced. And in round 4, results of genetic and MRI results was provided to the raters. And as you can see, the more information, of course, were provided to the raters, they were able to more accurately identify different types of pathologies. And they concluded that the type 1 and 3 remain the most difficult to differentiate from normal variation. And they recommended highly that the new clinical, pathological, and genetically defined subtypes be included in any FCD classification. That this paper then led to the ILA classification, a consensus classification in 2022. So now, of course, we'd like to improve. Our ability to detect FCDs, and these come really at improving our MRI protocols, using the opportunity of brain maturation, and also introducing some quantitative and post-processing methods. So in our young patients that present with very early onset epilepsy, lesion detection can be better visualized in an immature brain. In contrary to what we generally like to see in other neurological conditions, where we like to kind of get the patient to a point where the brain has been fully myelinated and maturated, in FCD, this provides a unique opportunity that some of the MRI features preceding the completion of myelination observed in the cortex, that subcortical white matter, can really demonstrate some increased visibility. And there's few theories behind this, whether there's some dynamicity to the lesions, whether there is some evolving features of the lesion, but also one of the plausible explanation has been the accelerated myelination that's been reported observed in patients younger than 2 years, usually around 6 to 12 months. And what you see here is in a same patient, image from a same patient from 6 months to 27 months of age. And what you see in images A and D is the T2 weighted fast spin echo image that's really showing some hypo-intense signal in the cortex and subcortical white matter here. And this is again seen in the coronal cut of coronal cut of the T1 weighted spin echo image. And this is again somewhat identifiable at 12 months of age, where you're still able to see some now subtle white matter blurring. And by 27 months of age, you can barely identify the abnormality. And in the bottom image, F, you can see that the subcortical areas have now have become very iso-intense. There is no hypo or hyperintensity to rely on anymore. So this, what could have been a very good window of opportunity had this patient only had the MRI after 2 years of age, that opportunity would have been lost. So this is important to keep an eye on. And of course, introducing the harness protocol that everybody, I'm sure, is well aware is really the Bernasconi et al. in the harmonized neuroimaging of epilepsy structural sequence, the harness protocol that they put out in ILA in 2019, advocate for 3D images of T1 weighted and FLAIR, and T2 and 2D, two-dimensional T2 weighted images, given that at the end of the day, visual inspection is still the standard approach to identify identify the focus and abnormality. Now, other new technologies that are really making their way into our into our routine in a way. However, they've not fully made it to clinical practice. Introduction of artificial intelligence. So the MELD study, which is the multi-center epilepsy lesion detection by Baxter et al., has had few publications, one of which was in Epilepsia in 2021. They developed a surface-based AI model trained on MRI data from hundreds of patients from across multiple different centers. And the model really analyzed the thickness, curvature, surface area, and intensity gradients. And they put out these heat maps. And based on these heat maps, we know that the hot spots are that you see the focal cortical dysplasias the most are superior frontal cortex, frontal pole, superior temporal cortex, and temporal pole. And they also did come up with a gradient that temporal lobe lesions mostly made up of larger proportion of FCD type 1 and 3, versus frontal lobe lesions were mostly made up of focal cortical dysplasias type 2A and 2B. This again helps us knowing what lesion resides in what lobe, can again really help us better understand what lesions we're dealing with. And finally, it's the quantitative analysis. And there's been a rapid rise in techniques for estimating and quantifying structural connectivity and functional interactions between different regions. These include the voxel-based morphometries, intensities, and texture analysis. In every epilepsy conference we go to, there are new techniques, new ways of looking at different brain MRI thickness, blurring, and folding. So it is really an up-and-coming topic, and the advances in MRI acquisition and processing really offer a window into a tissue microstructure and morphology. And what you see really here on your left side is, compared to controls, what we see here with the FCD, with FCD type 2B, all the intercortical layers show abnormalities, versus the alterations in FCD type 2A really remain confined to the edge of the white matter border. So these are things that we're able to rely on using some post-processing techniques. Now, these are really mostly in the research pipelines. There are many efforts to move them to the clinical side, but we all know that there are barriers to that. And now, before we move on to really discussing the genetic aspect of the focal cortical dysplasias, this was a study that looked at epilepsy surgery outcomes up to 5 years after surgery for all major classes of histopathological diagnosis and subdiagnoses for about 9,000 patients. And the study really provided very good evidence for a correlation between long-term seizure and drug-free outcomes, incorporating cause, age, and epilepsy duration. So here, they found the worst outcomes for compared, and of course, comparatively speaking, we often compare outcomes within FCD. Of course, within FCD, there is a gradient, but we know that the FCDs in and of itself perform, they hold the worst outcomes if you compare it to things like low-grade, if you compare it to outcomes of low-grade epilepsy-associated neuroepithelial tumor, vascular malformation, or hippocampal sclerosis. So they found the worst outcomes with some forms of FCD. They also identified that children were more often drug-free, and temporal lobe epilepsies were the best in terms of surgical outcomes. And what they show here is that the top tier really belongs to the group of hippocampal sclerosis, lead, and vascular malformation. This is then followed by, if we're talking about amongst the FCDs, FCD type 2B, and then lowest really belongs to FCD type 1, malformations of cortical development. Of course, in this particular study, they hadn't looked at MOGE, and when you don't have a no lesion were the ones that had the poorest outcome. And the factors that independently were associated with class 1 were histopathology, location of surgery, duration, and age. So now genetics of FCD, we're going to spend the next next 10 minutes or so talking about the genetics of FCD, understanding that over the last decade, there's been a growing evidence that there is a sort of what used to be a newer entity when I started my full-time job, and now it's sort of become the lay of the land. At the time, a couple of years ago, when we were talking about mosaicism or somatic changes in the brain tissue, this was kind of a rare entity, and now it's taken up the literature by storm. Just pointing out that the de novo somatic mutations really means that this mutation has happened post-psychotically, and it affects the neuroglial progenitor cells in the embryogenic cerebral cortex, and it increasingly is identified in patients with DRE, with malformations of cortical development, most predominantly over FCD. So just to bring everybody up to speed in trying to identify germline versus somatic mutations. So the germline mutations really occur before fertilization and are detected in brain and are clinically accessible by blood sample. And this is then followed by what we now know of a two-hit germline and somatic mutations, where you can see here that a germline, same gene, a same mutation. If you have a germline, a germline mutation in the same gene can give you a hemimegalencephaly. However, with the two-hit of germline and somatic mutation in the negative regulators of mTOR pathway, it can lead to focal cortical dysplasias. And as indicated, this depends depending on how much of the entity AAF, how much we have more of the frequency, the alternate allele frequency. The more the frequency, the higher and the extensive the malformation is. And additionally, if you have activation of somatic mutations in positive regulators of mTOR pathway, it can again lead to HME and focal cortical dysplasia, but again really comes down to what the gradient is, whether you have higher AAF versus lower AAF. And this notion of two-hit phenomena is quite important to also understand. Is the first one, which is the one hit, the hit that doesn't really cause a structural abnormality. That could be your germline mutation. That could mean that there could be a family history of epilepsy. However, your brain MRI is normal, and you would, on top of that, get a second hit, which would be the somatic mutation that then would cause the abnormality and the brain to cause the abnormality and the presence of focal cortical dysplasia. And there is a direct correlation between the dysmorphic loads and the somatic load, and it correlates with the extent of the epileptogenic zone. And this has now been well described in patients with DEP-DC5 as well as TSC. About 35 to 40% of patients with TSC have been known to have both germline and somatic mutation. And this was actually one of the first cases that was described was in DEP-DC5. And while we have the gene discovery in epilepsy has gone from the channelopathy era, then has moved into the dark ages, where there was kind of a few years of barely any new genes discovered, now to the genomic era of many genes that have been added to the pipeline. Very few have been refuted, things like SCN9A or CACNB4. Majority of them have been new genotypes and phenotypes that have been added to the gene discovery pipeline. But I really want to draw your attention to this nice tree map of what this paper by McNee et al. Put out in 2023 in the European Journal of Pediatric Neurology. They're really looking at the first tier, and they had identified about 150 genes that they put in the first tier epilepsy genes, and they've been divided based on the gene ontology, and the size of the boxes represent the number of studies for each gene. And you can see how you have a big box of channelopathy, again, the longest kids on the block. And then further, we see pathways, and this is what's really implicated in patients with FCD, and it includes many genes like TSC1 to DEP-DC5 and GATOR. So we've now discussed the histological findings of FCD, the MRI findings of FCD. I'm not going to get into the EEG findings for interest of time. And then we're now going to be discussing some of the genetic and epigenetic biomarkers of FCDs. And while there are some rare association with focal cortical dysplasia type 1, especially now with the description of MOGE now being one of the main genetic contributors to focal cortical dysplasia type 1, SLC35A1. Majority of the genes, both in somatic mutations and rarely germline mutations, have been in the focal cortical dysplasia type 2. So somatic mutation in the mTOR pathway activating genes, and they've been reported up to 6% of the cases, and rarely there is an association between the germline mutations in the mTOR suppressor genes and presence of FCD. And of course, there is a potential role for DNA methylation profiling. And as epilepsy surgery outcomes also can be impacted by the actual presence of a gene. And like we mentioned earlier, the location and extent of the lesion, of course, matters. But we're coming to learn more and more that genetic findings and having an underlying genetic underpinning can also really inform our surgical outcomes. This is just to show you that there have been many genes associated with different forms of malformations of cortical development. We're, of course, going to just be talking about the germline and somatic mutations that are associated with focal cortical dysplasia. The mTOR signaling pathway is one of our most, it's the pathway that's implicated the most when we're discussing patients with focal cortical dysplasia. We know that the mTOR is a central regulator, and it's involved in cell growth, proliferation, survival, and metabolism. And really, the dysregulation of the mTOR pathway leads to angiogenesis, protein synthesis, impaired cell cycle, and cell proliferation, and hyperactivation and abnormal cell growth. Another important upstream regulator in this pathway is comprises of TSC1 and 2. That's the key inhibitor of the mTOR complex, and mutations in these genes can be associated with TSC, FCD type 2, and hemimegalencephaly, and Gator complex, which comprises of DEPDC5, NPLRT2, and 3. These are the negative regulators of the mTOR complex associated with FCD's often normal MRI variants. And another important axis to keep in mind is the PI3K and AKT mTOR axis, and the mutation in these genes are well known and have been well described to be causing megalencephaly, polymicrogyra, and different variations such as MCAP, megalencephaly, capillary malformation. So now, what the question that is often being posed is the current challenge is whether our genetic findings can predict surgical outcome, the extent of lesion, and presence of multiple or bilateral lesions. Well, let's review the literature and see what we find and whether we can confidently say that genetic results are impacting surgical outcomes. So the epilepsy surgery in enteropathies, I thought the best way to go over that would be, again, to start by understanding the genes and which ones are on the germline mutation and some that are part of the somatic mutations. So the germline mutations, the genes that are implicated on the germline mutations are TSC1, TSC2, and the Gator pathway, which includes DEPDC5, NPLRT2, and 3. And we know the focal cortical dysplasia type 2 can be caused by these genes, and as well as hemimegalencephaly, tuberous sclerosis, and Gator1 related epilepsies. And the key features to consider is that the Gator1 mutations often result in MRI negative, but are linked to occult FCD. And the TSC causes multifocal tubers, and we talked about the second hit in somatic mutations that's been reported in DEPTC5 and TSC1 and 2. To name a few. And the surgical outcomes comparing the germline and somatic mutations is that it ranges between 58 to 71%. It really varies by condition. And the Gator1 related epilepsy is around 60%, and TSC is up to 71, but in the somatic mutation category, it goes up to 80% for focal cortical dysplasia type 2 and hemimegalencephaly. Now, there's been studies looking at really a deep histopathological genotype-phenotype analysis of focal cortical dysplasia type 2. And this study was done on 17 patients and was by Honke et al. In Acta Neuropathologica last 2 years ago, where they were able to confidently make some very deep genotype-phenotype analysis and correlation. They indicated that the FCD type 2A cases with Gator variants are generally associated with subtle MRI findings. Lesions are confined to the neocortex, and there's lower seizure freedom rates compared to FCD type 2B. Now, FCD type 2B patients were mostly with mTOR, associated with mTOR variants, that they do exhibit more distinct MRI lesions involving white matter and consistently achieve better surgical outcomes. Now, important to note that about 40% of individuals with FCD type 2A remain seizure-free after surgery. This is contrasting with FCD type 2B, where a majority of patients have been reported in this group to be seizure-free post-surgery. And they were the ones that, like mentioned, mostly are associated with changes with mTOR complex pathway. And so a divergent mechanisms underlying the mTOR1 complex hyperactivation in FCD2A and 2B suggest that there is different impacts on the migration and the cortical development. So the surgical accessibility and MRI visibility, of course, remain a crucial predictors of seizure outcomes. And what they ended up showing here is that different malformations of cortical development associated with the genes that they had identified, and these are all somatic, they were all confirmed by somatic mosaic analysis. So, for example, this is a 12-year-old with FCD2A and a 2-hit DEP-DC5 with no prior family history with Engel class 1. Here you can see this is a bottom of sulcus dysplasia. This was due to a DEP-DC5 germline mutation with Engel class 1. This is another mutation. This is another lesion in an FCD2, FCD type 2A, FCD type 2B with a mutation in the mTOR pathway with no prior family history and Engel class 1. So really, if we wanted to then summarize what we've learned so far is that if the current challenges, if we think our genetic findings can predict surgical outcome and the extent of the lesion and presence of multiple lesions is that we can confidently, based on what we've discussed, conclude that genetic findings can predict surgical outcomes, improve lesion detection, and inform better disease profiling. And also keeping in mind that the diagnostic yield of the mTOR-related variants in cortical dysplasias ranges between 20 to 80%. And so this is not as well as good. This is not all in well when we're talking about epilepsy surgery and channelopathies. I just wanted to make a very quick comparison, although it's not the focus of our talk today, is that there have definitely been attempts of epilepsy surgery in patients with different forms of channelopathies of SCN1A, KCNT1, which have shown to, which all show poor outcomes. There are some palliative procedures that, of course, are a good substitute for these patients. There's been some rare small case report for SCN1B when you do have actually an identifiable lesion on MRI that surgery could be effective in SCN1B. However, there isn't enough evidence for SCN1A or KCNQ2 to recommend any type of resective surgical interventions. Of course, palliative procedures are a viable option. Now, before we conclude and go back to our case, we've spent so much time talking about FCD type 2. Now, as I said, there's been rare association of even some of the channelopathies, some of the genes that are implicated with channelopathies like SCN1A and SCN1B with FCDs type 1. However, the biggest breakthrough has been with now linking the SLC35A2 variant to now what we know to be a distinct entity called MOGE, and this could also be seen in patients with FCD type 1. These patients generally present with two phenotypes. It could either be that patients with MOGE patients can present in two different phenotypes. Now, if the patient ends up having a MOGE variant, they usually present with developmental epileptic encephalopathy. Now, the second variant are ones that present with nocturnal or frontal seizures that actually respond really well to epilepsy surgery. And these two variants have now been closely linked to SLC3A2, 35A2. And here you can see a few examples of their MRIs, and important to note that these patients do better, better than patients with mTORopathies, and complete seizure freedom was achieved in 61% of the patients with epileptic encephalopathy and more than a third in those with drug-resistant frontal lobe epilepsy. And just for interest of time, I'm not going to really focus on the details of the pathology, only to say that that we have this again, even with the SLC35A2, there's a direct correlation with presence of the alleles, and when you have the VAF in patients with Engel 1, it was about 14% versus patients that had a poorer outcome had a higher VAF that was up to 30%. And this is important to note that has come to forefront of our clinical care, that there is a change age-related MR subtypes in relation to MOGE, and you can have this very nicely identified increased lamination, increased laminar T2 and flare signal that you can see in type 1 and subtype type 2. And this MRI change of and the change of this MRI subtype probably is due to the oligodendroglial maturation and subsequent myelation that happens between 3 to 5 years of age. So it's very important in patients that you're identifying or suspecting MOGE to go to the original and early scans to see if you can identify this laminar signal change at the corticomedullary junction. So now I'm just going to go back to the case, and now with that, with all the information that we had, we of course went back and reanalyzed our imaging, and we've done some post-processing here. And to just orient you, left is on the left, right is on the right, and this is not our usual conventional way of looking at MRIs. But we did identify that there was changes in the left parahippocampal gyrus. There was increased cortical thickness, white matter blurring, and we're also able to identify now, in retrospect, we were able to really now identify this in even other sequences, and we're seeing a hyperintense signal in T2. And so after 6 years from seizure onset, almost 6 to 7 years after seizure onset, this patient was then diagnosed with MRI positive focal cortical dysplasia. And based on what we've learned so far, majority of patients with germline NPLR3 mutations end up having a FCD type 2A, which could be a very plausible explanation. However, this wasn't where we were anticipating it. This was in what we could be a silent area, and there could be a rapid propagation to what our original area of the symptomatogenic zone, which seemed to be mostly in the insular opercular area. But given that this was a dominant hemisphere for the patient with intact neuropsych, and knowing that the response rate in patients with NPLR3 could be roughly around 40 to 50%, family opted not to proceed with surgery at this stage. And we've now implemented the use of sirolimus. So really, having had a genetic diagnosis for this patient was revolutionary on many aspects. So I want to just finish off by some few take-home messages, just really honing down the message that integrating neuroimaging and genetic testing can better improve and inform the path to surgery, that some in vivo signatures of pathological abnormalities are now being better identified by using advanced MRI techniques, and the genomics data should be considered alongside other modalities in those who are being considered for epilepsy surgery. And genetic results can have very positive consequences in search for precision medicine tools, such as presurgical germline mutation in GATOR1 associated candidate genes, such as the patient that we discussed. And we're really closer to phenotype-genotype neuroimaging integration. We learned today that the germline mutations in mTOR pathway can cause hemimegalencephaly, while two-hit mutations in negative regulators and somatic mutation in positive regulators can have, with varying allele frequency, can be linked to focal cortical dysplasias, hemimegalencephaly, and focal malformations. And also, more interestingly and importantly, that FCD type 2A cases are mostly associated with GATOR1 variants, and the FCD type 2 are associated with mTOR variants, mTOR complex variants, and they can each have distinct MRI features and have different surgical outcomes. And just to end with our last note, that SLC35A2 gene-related MOGE is really linked to two different distinct phenotypes, and these patients tend to have better surgical outcomes compared to the patients with the mTORopathies. So with that, I thank you, and I think we have 10 minutes for questions.